My name is Katie York, and I'm a respiratory care student. Today I'm going to do a case study on the complications of systemic lupus erythematosus, severe pulmonary manifestations resulting in fatality of a patient. So we'll start with the patient's story. A former fitness instructor and marathon runner, 37-year-old female, began developing arthrogallus joint pain, fatigue, and hair loss. She was treated with prednisone and diagnosed with systemic lupus erythematosus, SLE, on June 30th, 2020. Patient was started on hydroxychloroquine, steroids, and tramadol for the arthrogallus. On August 7th, patient was non-arousable by her 9 and 12-year-old at 9:30 in the morning. Her husband, a former EMT, immediately rushed his obtunded wife to the local emergency department. Upon admission, the patient was febrile, 38.9 Celsius, and tachycardic. Due to the unresponsiveness of the patient, she was intubated. CT of her head showed a right thalamic hemorrhage, and she was immediately started on a broad spectrum of antibiotics, ceftriaxone and vancomycin. She underwent a lumbar puncture, and it showed a decreased glucose and an increase in proteins. The patient's information: the chief complaint, she was non-arousable and recently diagnosed with SLE on June 30th. Admitting diagnosis, she had acute encephalopathy with bacterial meningitis, the lumbar puncture with decreased glucose and increased proteins, and a gram stain of pneumococcal was evidence of that. The right thalamic hemorrhage and shown by the CT and MRI, and she had ZERS, the temperature of 38.9 and tachycardic. She's 37 years old. She weighed, her height was 5'4". She weighed 52.6 kilograms. She had a recent weight loss of 25 pounds within the past couple of months due to the SLE, and she was allergic to amoxicillin. So let's overview the disease process. SLE is an inflammatory autoimmune disease. It can affect the joints, skin, kidneys, blood cells, brain, heart, and lungs. Her presentation with this, she had pleuritis with a small pleural effusion, pericardial effusion. She also had bacterial meningitis, which is the most dangerous of the meningitis. You can have a viral and bacterial meningitis. Bacterial meningitis, it showed the pneumococcus meningitis with cerebral ischemia. You can get a vaccine. It's the PVC recommendation for children and adults over 65, but this was not introduced until 2011. So the patient, being 37 years old, would not be in the range to necessarily be advised to get that vaccine. She did present with DVTs of the lower left extremity, right upper extremity, and the lower upper extremity, or the left upper extremity, along with systemic lupus erythematosus. It presents 40% of patients with SLE will test positive for APTS, which is a high risk of blood clots. This is the antiphospholipid antibodies. APS is a blood disorder where your body accidentally attacks normal proteins in the blood, which are made to control blood clotting. So a person with APS has a person with APS has antiphospholipid antibodies. These antibodies cause the blood clots to form. This leads to several complications, including DVTs, strokes, heart attacks, and miscarriages. She also presented with the bilateral hemispheric strokes and right thalamic hemorrhage. The patient assessment: upon admission and throughout her 3 weeks stay at the hospital, she remained comatose. She had bouts of Cheyne-Stokes breathing pattern, symmetrical chest expansion. Her heart rate maintained stable within the 70s. Respirations, 26, SpO2 at 100. We started her off with a FiO2 at 100, but quickly titrated down to room air, and she maintained on that. Her blood pressure was 141/82, a MAP of 97, and her temperature was controlled with antipyretic medication, but would frequently go above 102. Her breath sounds were clear and diminished. Her vent check, we would have her periodically go from APCMV, which is adaptive pressure ventilation. It's a volume targeted pressure controlled mode of ventilation on the Hamilton G5. Her rate at 10, tidal volume 400, FiO2 at 21%, and a PEEP of 5. And we would flip her back and forth on pressure support of 5/5. Tidal volume 300, and a minute ventilation of 7.4. She would tolerate pressure ventilation for a long time. I believe 20 hours she stayed on pressure support without tiring. But we frequently had her put her back on APV-CMV. The patient's lab values. So she did have an increased white blood count, low RBC and HB. Her hematocrit would be low. She did have normal potassium and sodium. Her chloride would be high, and her BUN would sometimes be high. Her glucose was normal, her platelets were normal. I do want to note, though, her PT, T, and INR was normal at the time I documented this, but upon admissions, or this was on a heparin drip, upon admissions it was elevated due to the APL antibodies that were present. So they quickly put her on a heparin drip for that. And her ABG remained compensated once we established a mechanical ventilation. Her chest x-ray did show mild cardiomegaly due to pericardial effusion. This was due probably because of lupus and the fluid overload. No interstitial or alveolar edema, slightly improved aeration on the left lung base, and right lung was clear. Minimal atelectasis due to the comatose and non-movement, swelling of the lung parenchyma, pleuritis, and this was most likely due because of the lupus and the fluid overload as well. Medications that she was on, they had her on acetaminophen for antipyretic, hydroxychloroquine due to the immunosuppressive drug and the antiparasitic, ceftriaxone, the antibiotics for the bacterial meningitis, Keppra for the anticonvulsant, magnesium sulfate for the hypoglycemic, Protomix for proton pump inhibitor for GERD, and the heparin drip due to the DVTs that she had. So she was admitted on 8/7. By 8/18, the patient started hemorrhaging out of her mouth from an unknown source. Her H&H started to trend down, and she became hypokalemic. The heparin drip was ceased, and electrolytes were replenished. Pulmonary wanted to perform a percutaneous trach and therapeutic bronchoscopy. They wanted to wait till she stabilized from the bleeding. It did take several days. On 8/20, after 2 days of persistent bleeding from the mouth, the patient became stable enough to perform a trach and bronch. It was a size 7 Shiley trach, was placed in residual bloody mucus with suction from her lower airways. On 8/20, the heparin drip was reinstated due to the ultrasound, which indicated a left and right upper extremity DVT, and also a lower extremity DVT that was also seen prior. Diagnosis and outcome. Due to the late diagnosis of the SLE immunocompromised and increased risk of DVTs due to the increased antiphospholipid antibodies. Also due to the late diagnosis of the pneumococcal pneumococcal meningitis. 1 in 5 people will die of bacterial meningitis. If survived, long-term brain problems occur, 25 to 50% resulting in brain damage, deafness, learning disabilities, and paralysis. On 8/20, the patient got a trach placed, and the peg was they wanted to place the peg as well, feeding tube, but the patient was unstable after they did the trach. Due to the patient, they wanted the trach and peg for an LTAC. The patient's family wanted to continue care. That would be the next step for her. That would be the long-term outcome of her going to a long-term care facility, ventilated, and with a trach and peg in place. On August 21st, the husband wanted weekly brain scans to evaluate the improvement of her brain activity due to the thalamic stroke that she did have. There was minimal brain activity being shown. This was one of the first times that I worked really closely with palliative care as a respiratory therapist. And I saw this patient from an admit all the way until her death on August 31st. The husband did, on August 26th, the husband did decide to withdraw care. The brain scan showed no improvement of brain activity, and from prior conversations with his wife, he knew that she did not want to live in a state that was dependent upon a ventilator, especially with their young children and all the complications that go along with that. So on August 26th, the patient was extubated. Husband stayed by her side throughout the 5 days it took her to actually pass. She had a lot of guppy breathing. She was put on comfort care, so she didn't feel much pain. We would frequently take her out onto the balcony, and her husband could sit and look upon the mountains, the Colorado Rocky Mountains. But at 5 o'clock on August 31st, the patient did pass. This was one of my first patients that I saw from beginning to end. In fact, I did speak with the patient before she had her stroke, because I knew this patient before she came into the hospital. So it was a very emotional patient for me to take care of, but at the same time, I learned so much throughout the course of caring for her and her family, and working closely with palliative care. It made me proud to be part of a system that showed so much caring throughout it. The family had expressed their gratitude of palliative care, RTs, and the RNs that work so vigilantly on this patient. At the end of everything, we did do a 5K memorial run for her. And numerous staff from the hospital was there to support the family in the small community that we live in. Unfortunately, this patient was not able to be an organ donor, and that was something that the family is trying to work on with legislation. And it had to do with her being ventilated for a certain amount of time and the stroke that she had. So I would like to do further research on that, and I've been working closely with the family to see what all the terms are for organ donors, because she was so young and so fit prior to her diagnosis with SLE. And these are my works cited. Thank you.